Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
And good morning, everyone, or good afternoon, whenever you're listening to this podcast. Another episode of Health Law Talks with your hosts, Conrad Meyer, Rory Bellina. Rory, good morning.
Good morning.
Two experienced healthcare lawyers bringing you the latest and greatest in healthcare law or policy, right?
Yeah. Today we've got an interesting topic.
We actually, you know what? We actually do. I think it is interesting. It's kind of timely in some respects for me, but what is it? What's on the slate today?
Yeah, so I think a topic that we get a lot, and it comes up more and more as you see physicians get a little bit later in their career and they're investing in different things, but particularly surgery centers or ancillary services, is this concept of economic credentialing and maintaining their medical staff privileges within that and their ownership too.
Right, and absolutely. And when you say the word economic credentialing, I don't know people understand what that means. What does that mean?
Yeah, so
to you,
and I think that I don't think there's a hard and fast definition of what economic credentialing is, but it's the concept of remaining credentialed or remaining to have your privileges, or even so far as still being an owner in a center, based on essentially the economics of what you bring to that center.
How much you bring in.
Correct.
Right.
Correct.
How many cases you do, what you bring to the table.
Correct. And it could be valued at number of cases, reimbursement rates, just total profit that can be brought to the center based on cases that you're performing and referring in. So there's definitely different ways to measure it, and there's regulatory issues with it, but you see it come up with most ancillary services and surgery centers because it kind of has to be measured and done. Otherwise, you could run into financial problems within that center.
Or in some cases, if you're lucky enough to still have a private hospital, right, with physician ownership in that context. So surgery centers, private hospitals, the ones that are still left,
sure,
post ACA, right, and other ancillary services or entities, right, that have physician ownership in.
And I think it's a good way to explain this to our listeners is to explain kind of how this starts. And it typically starts with, if you're offered a piece of ownership, what happens after that? So,
we'll start. The easy one is the hospital.
Right.
Okay, so you have a private hospital that is physician owned, and you're brought in, and of course it's a hospital, so it's a business. It's a business. And in order to make the business run, you need to have cases. And so how do you ensure that your physician owners who are reaping the benefits of ownership through a distribution of profit of the hospital,
correct,
also bring in the cases to the hospital, right, for that revenue? So
and can you even do that?
Can you even do that?
Can you do
right,
that?
Right. Under a regulatory scheme. So technically, you can't under a regulatory scheme, even if it's just a private hospital with no Medicare and Medicaid, because usually your state has some sort of an anti-kickback law like Louisiana does.
Correct.
So to get around, I guess, or to skirt the issue, right, you couch the number of cases in terms of patient quality. And you put in your bylaws that each physician must do a certain number of cases in order to meet competency for patient safety. And there's a reason for that too.
Yeah, what's the reason for putting in there a floor on number of cases that a surgeon must perform at the center?
It's couched in quality and it's couched in patient safety. So in other words, we want to make sure that you, Dr. John Doe or Jane Doe, has the ability to provide the professional medical services in a very safe and competent manner. And the only way we can ensure that you can do that is through the number of cases that you perform. So just like anything else, I mean, the more cases you do, the better quality or the better competency you have because you're doing it more. And we can see, we meaning the administration or the medical officers can see that doctor is doing X amount of cases. So if there's no complications, no callbacks, nothing like that, then you realize the doctor, hey, that person is competent. However, it also meets the business need of that facility because you're bringing in the revenue, right?
You can kind of benchmark if Dr. Doe is doing, if he's required to do 20 cases and we expect to be reimbursed X, 20 times X that's how much we can expect to get if we bring him on as an owner.
Correct.
Okay. If I'm the government or a state agency, though, do I think that runs afoul of a volume-based kickback?
Well, absolutely. I mean, you're telling someone they have to bring in X amount of cases in order to make the revenue, but it's kind of, I guess, it's skirting the issue because you're couching it under patient safety, but in the same sentence, you're also requiring revenue to come in the hospital, which, remember, you can't pay any remuneration for patients.
For volume. Or
volume-based, right, correct.
This is requiring a volume-based
commitment.
Correct.
Right.
And so, in your experience, have you run into any issues with it outlined as you described, patient safety, but it has a floor of X amount of cases per month or per year?
I think the issue comes in to play, right, when you're the administration and you're seeing the numbers and you have physician owners who aren't meeting the criteria but yet are getting profit distributions. And so in your mind, you're thinking, well, this doctor, kind of behind the scenes, you can't, it's sort of this unwritten, this unspoken rule, right? That, hey, I need Dr. John Doe, who's supposed to be doing 20 cases. This doctor's doing 5 or 10, but yet getting profit distributions. Again, when you look at all the doctors on the owner side, how do you think those other owners are going to feel if they see this one doctor not up to snuff? He or she's not doing the number of cases. Do they want to give that doctor a check every distribution?
So is it really are you really concerned about patient safety?
I think you are. I don't think it's just about profits. I think that there's a general feeling that you want to have. In order for your hospital to be able to survive, you need to be able to hold yourself out to the public as something of a very high quality. To ensure that high quality, I think it meets both standards. I think by doing the number of cases, you can show competency. You can work within the guidelines of the hospital. So therefore, you can advocate to the public that, yes, we have a very high quality, competent physicians, staff member that does cases here. And in the same token, in the same side of the coin, you can then ensure a revenue stream within the hospital, right? That would be viable not only for just survival, but also for a profitability in a sense. And then and nobody can really, how can you question that? In other words, if I'm a government regulator, if I'm the DOJ or if I'm the AG coming in and in my bylaws I say, you must do 20 cases at this hospital to ensure patient safety and competency, who am I? How can I attack that?
That's true.
Well, wait a minute. What if
it's?
I knew you could go ahead.
Okay. What if it's you must bring in X amount of revenue?
That's different.
Okay. Totally different.
Because now you're putting a dollar figure on it.
Now we're putting a value figure on it because you could change it for each specialty.
Yes.
Each doctor.
That was my next question.
Or how much they invest. If they invest more, do they get to do less cases, or less dollar amounts?
Well, that was where I was going with that. So now, what if the bylaws said, well, neurosurgeons only have to bring in 2 cases?
Right, because their reimbursements are so much higher.
Right. Well, but I think then you get into trouble.
So your recommendation would be to bring in everyone under the same threshold of a minimum amount of cases, no matter the specialty.
It's neutral.
To meet not to meet, but to feel comfortable that you can't be called out on a volume-based remuneration.
Yes, I mean, and that way it's neutral. It's revenue neutral. Well, it's not revenue neutral, but in other words, it's a neutral number, right? But here's the problem. Here's where you're going to run up an issue on that. So let's just say I'm the neurosurgeon and I'm told on the bylaws that say the number is 10 cases. This is, I mean, I'm
10
just
cases per year.
pulling something out of the air,
Right.
right? And my revenue on 10 cases happens to generate
$10 million.
$10 million, right? Whereas, you know, maybe somebody else's revenue on 10 cases is only $500,000. And yet I have the same percentage of ownership as the person who only has $500,000 of revenue versus my 10 million. How do you think I'm going to feel?
Yeah, I mean, you're going to feel that you either don't need to do as much cases over there, or you should be getting more because you bring more value to the center.
So how do you manage that? If you're the administrator at the hospital, if you're the lawyer to the hospital and you get the call, what do you tell them? Have you seen this before, Rory?
Yeah,
what do you say?
It's come up a lot. It's come up in a lot of conversations, predominantly that I see with surgery centers, because you have these surgery centers that are built. They typically take a fair, you know, a substantial investment to get off the ground, to get, you know, depending on the type of the center, if there's any licensing that needs to be done, and then, you know, staffing it, the equipment, all
Right.
that. So there's a significant upfront cost, and then you want to recoup that cost as soon as possible. So the question comes up, well, we've recouped that cost, and like you said, we've got this one doctor who has a 5% ownership, and he does one case over here because he has an ownership at another place where he's got a bigger ownership interest, or he lives far away, or he or she, whatever it may be.
Right.
That's where it comes up, and you, like you said, you've got doctors that get frustrated because they're doing a lot more volume, a lot more cases at this surgery center. You've got another doctor who they never see, but they're all getting the same check or, you know, distribution every quarter.
So then now we're treading into the economic credentialing.
Yeah. So you get the call from the administrator that says, Conrad, Dr. John Doe he's done one case here this past year. He's not meeting the bylaws that say he has to do 10. You know, can I kick him out?
And that's when, you know, well, first off, I want to see the bylaws, right? You want to make sure. And then are the bylaws, I guess what you would say, economically neutral, right? In other words, by having the same number of cases, I have an argument to say that this is the bare minimum you must meet in order to be competent and ensure patient safety at this hospital. I mean, it would sort of be like riding a bike. You know, if I rode a bike, you know, once a year and decided, well, hey, you know, I'm just going to ride this bike one day a year, versus if I rode a bike, you know, 10 days out of the month, every month out of the year, who do you think would be more proficient?
Right.
I mean, I guess it's riding a bike, but I mean, still, I think the more times you do things, there's an argument to say that the measures in that facility, whether it's a surgery center, whether it's a hospital, whatever it is, that you're going to be well versed in that facility's culture, in their methodology, and that they themselves will in turn see your competency. So
let me change the facts that I just gave you. You've got a doctor who is
I love when you do this.
He's I don't know what kind of doctor. He's a general surgeon.
Okay.
You know,
yeah.
Fixes breaks and bruises and that kind of thing. And is meeting the requirement. Mm-hmm. But he's meeting just that requirement, and he's
bare minimum,
and he's bringing low reimbursement cases, and he's still getting the same distribution as the neurosurgeon who's bringing the high reimbursement cases. All the doctors are talking; they're mad. You've got your neurosurgeon who says, "I'm going to sell, and I'm going to go across the street because I'm going to get a bigger piece of the pie." What do you do in that situation?
That's a tough call. That's a real tough call. I'm going to try to motivate, right, my lower performing physicians into coming in and doing more cases. And I'm going to.
But how do you do that if this general surgeon who comes in and he's doing 10, if he does another 15 or 20, that might be another $10,000, you know, to him. It's not worth his time. He's doing fine, just doing the minimum and getting his distribution every quarter. How do you do that?
I think that's a tough nut to crack.
Okay.
I mean, that's really hard. So, the only thing I can do is bring that person in, sit them down, and say, look, you need try to motivate them to bring in more work into the facility, and really focus on the fact that not only do we have the highest patient standards and the highest or the lowest readmit rate or the lowest infection, acquired infection rate, but that this is a business too. It's not just that, this is a business, and the business is not going to run itself, if you just, walk away and hope the lights stay on.
Now, do you have that, in having that conversation though, are you concerned that your administrator is going to essentially be saying you're not bringing enough volume or value here? And you're going to have an improper termination, and you're threatening to terminate
No, because you don't do it like that. I mean, if the bylaws say that you have to bring 10 cases in, then guess what? If that person's bringing 10 cases in, there's really nothing I can do.
So how do you get him out?
Well, you can't unless it's done through. Right. I mean, unless you're targeting someone.
Sure.
But the only way you can really, honestly, the only way that you're going to be able to do that is if, one, they don't renew their privileges,
right.
and two, either they're incompetent, they're impaired, they have a behavior issue that threatens patient safety. I mean, that's really the only two ways. The only two ways to do it. I mean,
so at that point, your administrator just has to be aware of, here are the ways that they could be terminated. And unfortunately, some of the administrators are probably going to be looking for that then, because they want to get that low producing physician out.
I think unconsciously, yeah.
Yeah.
I don't think anyone would ever admit that.
No, of course not.
But I think unconsciously, if I know that, one of my doctors who's a lower, gross margin physician who only does the bare minimum to get by,
you're going to be checking all of his notes.
I'm checking everything, because I mean, remember now, if they're impaired, if they're disruptive, if they're incompetent, anything that jeopardizes patient safety, right? That's an actionable offense. I mean, any physician would.
Sure.
I mean, it doesn't matter if it's the highest margin or lowest margin,
sure.
but let me just say this. I mean, I agree with you. If I'm looking at something a little more closely, it's going to be the one who's going to lower margin, right?
Correct. And I think that you're having administrators that will look and see, was he late on his notes? Did he not?
And they will never admit that. They will never. You will never get them to admit that. They'll never say that, but they're actively doing it.
Correct.
Because if I'm, for example, say I'm the one of the top 3 grossing physicians at that facility, do you think the administrator's heavily looking at the notes or the competency level of that physician versus the guy or the girl who's doing the bare minimum to stay qualified under the bylaws?
Absolutely not.
No.
They're going to look for a way to legally get out the doctor doing the low amount of cases.
I mean, that happens all over the country. It happens everywhere, I'm sure. You know, and it happens not just in hospitals, but I'm sure in regular workforces. I mean, if you have someone that is, that you feel might be a liability, but you can't terminate them on grounds, you're trying to find other ways to do it.
Sure. So let's say you represent the doctor who has now been terminated. He is the low producing or, low volume case.
I know where you're going with this.
And he comes to you and says, hey, they kicked me out. I was doing what the bylaw says.
Right.
They said I was late on notes, and I think this is a weak way that they've terminated me for. What are my options? What can I do here?
So at that point, obviously you want a copy of the bylaws. You want a copy of whatever the MEC has, the Medical Executive Committee has in terms of the delinquencies or whatever the charge is, right? If it's failing to do the medical records timely, or if it's, botching up the surgery order, right? So you're delaying other surgeries and that could affect patient safety. Whatever the issue is, you need to see, what are the requirements? Did he or she violate those requirements? Because I think it's really hard to defend yourself on an economic credentialing when they're kicking you out over competency issues, and you've actually violated those competency issues.
Even if it's the most technical thing, I didn't wear purple scrubs on Thursday,
right?
And they kicked me out for that. The smallest thing. That's why I always, when I'm meeting with someone or talking with someone, and they're looking into investing in or doing something like that, and it always says. It's always going to say in their buy-in, I agree to abide by all the rules, policies, procedures.
Sure, yeah.
Always ask for a copy of that, because you don't want something to be snuck in there. And I always use the purple scrubs as my example just because it's easy. is you don't want something to be snuck in there that you have no clue that you're violating it, and you're that guy doing the low amount of cases, and they get you on it. Conrad, you didn't wear purple scrubs last Thursday. You violated the bylaws. You're out.
I agree with that. And you know what else I tell on the flip side? Not just the doctor, Rory, but administrators and CMOs. I tell, make sure that you actually read your bylaws so that when you do decide to take action, you do it properly. I can't tell you the number of times where I've gotten calls after the fact of administrators or CMOs, chief medical officers, or even MEC who have taken action on a physician after the fact, right? And we're getting to the point where that physician is requesting a panel, a hearing, a fair hearing through the bylaw process. So, and I asked them, well, tell me what led up to the request for fair hearing, and they go through. Well, we noticed this. We did an investigation, and so wait, time out. What do the bylaws say you must do? And then suddenly, when you look at what the bylaws require and what was done, they didn't follow it. So in other words, say for example, the bylaws say that in order to start an investigation, I mean, it does. Sometimes they don't say this, but that you must give the aggrieved practitioner some notice through like, MEC is hereby starting an investigation, and the bylaws require that, but you didn't do it. Well, then guess what? You have not given that aggrieved doctor notice. So I tell administrators, physicians who are part of the process, know your bylaws, know what you need to do, and usually get the attorney for the hospital involved at the front.
Because usually you prepare the bylaws for, I keep using the surgery center as an example, when they're getting started,
yes.
When they're bringing people in, and
they put them away.
It goes in a filing cabinet, and it's never looked at again. And then when you want to get someone out, or if you're having an issue, or if you get someone out, and then they get an attorney involved, and you find out you didn't follow your own bylaws, and then you've got a huge issue, because then you get into issues of, well, a lot of bylaws will have different things. I was talking with someone recently. A lot of bylaws will have, well, if you're terminated for cause, we get to reduce, or if you've got shares, we need to buy them back. We get to reduce the value of it.
That's true for evaluation.
Correct.
On a redemption. I got it.
But if you're terminated without cause,
right,
then you get the full value. So
right.
I think that becomes very important, because you don't want to get into a situation where, okay, we've got Dr. Conrad. He didn't wear the purple scrubs on Thursday.
That'd be a terrible rule, by the way.
I know.
Purple scrubs?
I'm an LSU fan, so I use it for that reason. And I use it because it's ridiculous.
It is
but
ridiculous.
It's simple to understand that there could be something in the bylaws that you
is ridiculous.
Don't know about. But did the administrator put it in there purposefully to have a golden ticket to get someone out? Did they put in there like a little safety parachute for them to get anyone out?
Now you sound like Willy Wonka.
That's true. And I lost my train of thought now that you.
I threw the Willy Wonka. I caught you. I got you, didn't I? Well,
now I lost my train of thought.
But you know what? Wait, I want to tell you this though. So the problem. So now you have a due process issue if you didn't follow that, right?
Yes.
And you might have to unwind what you've done and go back, because remember, there are time limits. So in other words, once an adverse action has been taken on the privileges of a physician, that physician, usually in the bylaws, has some time period to request a fair hearing, and you have to go through proper notice. So in other words, I think it's some bylaws, most bylaws say 30 days or something like that, and that the way that the physician must request a fair hearing is very specific, that you have to send a letter to the CEO requesting fair hearing. And I recall in one case, I'll give you an example, the doctor emailed the CEO, and nothing was ever done.
The CEO never got the email?
Well, no, I think the CEO got the email, but in the bylaws, it didn't say the notice. The notice must be by written certified mail.
Ah.
So in other words, the email, according to the bylaws, did not suffice. Now, if I brought that to court, I guarantee you a judge would look at me or look at the CEO sideways and say, are you telling me that you knew about this in an email and you're telling me you didn't have notice?
Sure.
I mean, that's kind of silly, right?
Right.
But that kind of specificity, you don't want to have to go to court on that.
Right.
I mean, you want to get it done right from the beginning, right?
And if you're back on the administrator side, and if you want to get someone out, you really want to make sure that it's done properly, because if you don't, now I know where I was going before. If you don't, there could be a situation where it changes from a terminated with cause to a terminated without cause.
Yeah.
And then you're paying them more than you expected to on redeeming out their units or their shares.
Well, one thing in Louisiana through the Granger case, I don't know if you're familiar with that case. That case is a Supreme Court case. It dealt with medical staff bylaws, and it laid out now by jurisprudence that the Supreme Court now has said the bylaws in Louisiana are contractual. So it's before Granger, pre-Granger, they were not considered a contract. Now it's a contract. So I tell administrators and physicians, you know what? If it's a contract, you have to abide by the four corners of that bylaw agreement. And so if the bylaw agreement says you must do X and you fail to do X, you have breached that contract. So and I agree with you. It gets dusted off, right? After you'd have to wait probably the formation, right?
Sure.
And then nobody sits down to go through it and say, hey, let's look at this. We might need to revise this, and it could be anything. It could be from your patient safety, right, competency number of cases to your due process and fair hearing plan process, right?
Sure.
So I mean, it's
and you brought up revising. That's a good point. Is you could get into a situation where you realize that you need to change your bylaws because you do have physicians that are not doing enough cases to meet patient safety, or frankly, they're not doing enough cases to keep the lights on. And so you have to go into your bylaws and revise them. But then at that point, if you don't think about these issues on the front end, are you going to have enough votes to revise your bylaws? Because the doctor with the low amount of cases might not vote for it, and he might be able to hold up a change that's going to affect him if he kind of sees what's coming.
True. I mean, that's very true. So why try to get it on the front end is what you're saying?
Yeah. The point that I was making with that kind of
do it at the beginning
narrative is you really want to put in protections on the front end.
And let me ask you this, because I know this happens. So say you have a client that calls you and you're doing a surgery center, right? How often when you sit down and say, okay, guys, girls, here we go. We're going to need, and what kind of entity we're doing here? We're doing, an operating agreement. What are we doing here? And then it comes down to, okay, as far as the facility goes, we need to have some sort of bylaw provisions. And when they get to that, when you get to the bylaw, oh, guys, we have to have some bylaws here. What sort of reception do you get when you say at that point?
That's the part where they're like, we'll get to that, or we could take care of that later. No one ever wants to do that because it's usually time consuming, a lot of talking back and forth. It's an expensive document to just prepare. So a lot of times when I bring that up, they say, well, let's
just download it from Google,
yeah,
right?
Let's just get formed with the Secretary of State and get us our tax ID, and we'll figure out the bylaws. We'll figure it out. As usually, we never do it. So,
like the worst mistake.
Sure,
mistake,
because you're losing out on protections that you need to have in place for yourself.
I mean, I give you the case. I can't remember the case. It wasn't. It was a Texas case. Okay. And I don't know it. I can't remember off the top of my head the name of the case, but basically it was a cardiologist who was doing catheterizations in the cath lab, and he had a higher mortality rate than normal, and the chief medical officer, or was it the chief medical officer, was maybe the chief of cardiac surgery, came in, who was also a competitor, summarily suspended the guy because he said, you no more caths for you. You can't do any more caths or what have you. Summarily suspended the guy. And then ultimately, through the suspension, he got kicked out. Okay. Well, he sued the facility on economic credentialing because they didn't and lack of due process in the bylaws, because the summary suspension that was issued by basically his alleged chief competitor,
Sure.
and the chief of cardiology was not a person listed in the bylaws that could issue a summary suspension. So basically, it was improperly issued by a competitor. You know what the jury awarded?
I do not.
$300 million plus. Now it got ultimately knocked down.
Sure.
But
still, they
300. Do you want to go to a trial and
Right.
you know? So
and pay interest until the appeals are up.
man, it's terrible. So I mean that was one example, Rory, of the
point
bylaws.
of that
right.
is that
Follow the bylaws.
follow your own bylaws. Have bylaws. Make sure you know what they say. If you don't know what they say, contact
that you don't
somebody.
download from Google, please. Right.
Right. And make sure that you're really thinking everything through. And look, it happens all the time. If you need to get a doctor out because they're low performing or whatever the case may be, you have to talk to someone to find out if you can do it, how you could do it while being comfortable with the risk associated with it. Because odds are, if you terminate the lowest hanging fruit, the doctor who's doing the lowest amount of cases, they're going to know it, and they're probably not going to be happy with it. And they're probably going to get an attorney involved and say, this is economic credentialing. I was wrongfully terminated. You're violating the state anti-kickback statute, and I'm going after you now. So you have to be very comfortable with your own bylaws to be able to defend how you got this doctor.
And that's where knowing your bylaws is very important. That's where knowing where you have the teeth, right? So you have the minimum case number for patient safety, which I think any of us agree would be appropriate as a defense,
and
right?
then you could have some more subjective things in there that you
maybe the number of callbacks, right, for acquired infections, and that could be under safety issue. Your continued upkeep of certain maybe CME.
Sure.
I don't know, bylaws that really get into that weeds.
Have you ever seen a situation, though, and I can't think that I have you ever had a situation where a doctor's kicked out, they challenge it, and the surgery center provides the criteria on why the doctor was kicked out, and then that doctor in turn says, well, everybody's doing that. No one's doing their notes on time. We've all got this callback rate or this complication rate. You know, I think, again, this goes back to the theme of our conversation today is that, you know, are you comfortable saying that, okay, Dr. John Doe, he really was low at the bottom and no one else is having these issues?
Well, if the administrator calls me and tells me that fact scenario, the lawyer in me is going to tell the administrator that you need to apply the bylaws evenly.
Correct.
So you can't cherry pick and
Rules.
say, right, you got if everyone else is having callbacks, and guess what, those folks need to be on notice too. Otherwise, you're opening yourself up.
You're picking out. You're finding a reason to get him out. And
right.
And these doctors know. They all talk, and they're
not stupid.
They all know,
know
that. Oh, this is a rule in our bylaws that no one follows, but they're just using it against me because I don't do cases there.
Well, one thing that you can do, and I think it's good, is if you don't do it in the front end, you can always take the bylaws, do a revision, and do a vote. You do a vote. Say, look, we're in order to continue our record of great patient safety and low hospital acquired infections and low callbacks, we want to up the case number from 10 to 20 or whatever it might be, and vote. And if everybody votes for it, then there's no issue. Then now you have a new baseline.
Sure.
But I agree with you. I think it's best to do that at the front end.
Sure.
Because as you progress, right, you sort of figure out who's doing what. And the only other option you have, if it's not the number of cases, remember, is are they impaired?
Right.
Are they disruptive?
Right.
Or are they incompetent?
Right.
Because then you could do your FPPE or OPPE. That's a whole nother conversation. Sure. But then, and I'll be candid with you. I've never had a doctor come to me and tell me that, hey, we have an economic credentialing problem, because usually what I say is, okay, tell me what's going on, and it's always some competency issue. It's always, oh, they made me do an OPPE. I had to go to this program and get evaluated, and the recommendation was that I do X, Y, and Z, and I'm like, well, then what do you want me to do? I mean, you got called out on competency, you got evaluated, they told you the recommendation, follow the recommendation.
Right. But basically, I think that the takeaway here is that you can't tie in your owners to bringing in a certain dollar amount or threshold,
you're going to get bit.
You're going to get in trouble for doing that. So if the financials are not working for that physician, you cannot base your decision on that. Now, in the back of your mind, is that one of the factors? Yes, it probably is for some administrators.
I know it is.
But you have to be able to defend it in other ways.
And that's how you defend it.
Correct.
Correct.
So have good bylaws. Make sure that you don't violate economic credentialing in that way.
Well, as usual, Rory, you give sound advice. If I was a doctor, I'd be your client.
Thank you. Same for you. Thank you.
Well, thank you. Well, look, I think that's going to wrap it up for another episode of Health Law Talks here at Shahardi Sherman-Williams. We have enjoyed this episode, and look for the next one coming up soon. We'll get this up in the air shortly. Enjoy. Have a great week.
Thanks for listening to this episode of Health Law Talk, presented by Shahardi Sherman-Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardi Sherman-Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardi Sherman-Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.